Hey, everybody, welcome back to another episode of Confessions of a Male Gynecologist. I am your host and hormone doctor extraordinaire, America's holistic gynecologist, Shawn Tassone, and author also of the Hormone Balance Bible that you can get now on Amazon. It's in the top 100 books in women's health on Amazon. And I wanted to talk today about a topic that I think gets a lot of I think it gets a lot of publicity, probably because there's a lot of celebrities now talking about it and kind of, I guess you could say, cashing in on it, for lack of a better description. But what I'm seeing is this new push towards marketing and selling things that are related to perimenopause. And the issue that I see with that, while it's great on one hand because it is bringing a lot of attention to the aspect of menopause and perimenopause, the thing that's bothersome on the other hand is that this is something that is getting used and abused because the celebrities, i.e., Halle Berry, Gwyneth Paltrow, Drew Barrymore, they're all selling something. And that's the thing with this perimenopause state, is that they are realizing that there is money to be made, and the supplements that are coming out for perimenopause are fascinating to me. So what I wanted to do is just talk about perimenopause, talk about the symptoms of perimenopause, what it is, why it is, and then talk about how you can kind of deal with it without falling prey to a lot of the crazy supplements, because there are some good supplements. There are a lot of great companies out there that are doing some good work, but there are also a lot of predatory companies out there that are making tons of false claims. And the problem with perimenopause is that a lot of women are out there suffering and they're not really getting the help they need, and they're being gaslighted by my colleagues and others. And so they don't know where to turn. So when they're awake at night and you're listening to, YouTube or whatever, you're getting bombarded with all these ads. And the problem is a lot of these ads are negative, or they play on your pain points. So what the hell is perimenopause, and when is it, and why is this now all of a sudden becoming a part of the lexicon that we hear on social media? Suffice it to say, the Latin basis of perimenopause, peri-Latin just basically means around. So you have a time period around menopause. Now, perimenopause in and of itself is not a disease. It's not necessarily a diagnosis of something in the sense that menopause is. Perimenopause just means the time around the menopause. And that can be for many women mid 30s to mid 50s. It's a huge time period in a woman's life, and it's not a diagnosis, meaning you can't just, everybody wants to know, am I in perimenopause? I hear it all the time. The problem is there isn't a diagnosis for perimenopause. There's not a lab we can draw. It's a conglomerate of symptoms. It's more of a syndrome, a conglomeration of symptoms and signs that you can then combine with labs and come up with a diagnosis of sorts. It's like polycystic ovarian syndrome. There isn't just one thing that makes you say that you have PCOS. And unfortunately, a lot of women are misdiagnosed, meaning they're not put into the perimenopause phase, or they're being overtly diagnosed with perimenopause and then prescribed something or told to buy something that may or may not work. So perimenopause in and of itself is just the time period in your life around menopause. So when women ask me, am I in perimenopause? Yeah. I mean, if you're in your 40s, you're perimenopausal because you're around the menopause. But what are the symptoms of perimenopause? What are the signs of perimenopause? And then how can you work with those signs and symptoms so that you can get the help that you need and not fall prey to a bunch of trash? Well, one of the big things I see in perimenopause, you're going to see a lot of these healthcare providers, experts, blah, 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 saying that the first hormone to go is progesterone. I don't know if that's necessarily true, and nobody knows the answer to that. So anybody definitively saying that's a thing, they're making that up. But suffice it to say that irregular ovulation does happen very commonly in perimenopause. So you may have a decreased level of progesterone in the sense that you're not ovulating as frequently, but it doesn't mean that progesterone actually wanes during the perimenopause phase. However, it could be true. It's just not a scientific thing. It's something that people are anecdotally coming up with. And so, again, they're selling a supplement, some perimenopausal formula. But suffice it to say, if perimenopause is a decrease in progesterone production, let's just assume for a minute that's true. What are the signs and symptoms in perimenopause of a decreased progesterone production? Well, primarily is going to be insomnia. Women that used to sleep well that now have issues with sleep. They can't fall asleep. They can't stay asleep. They have more daytime anxiety, more irritability. This is why a lot of women will get diagnosed with anxiety or depression in perimenopause, is because of the potential downfall of progesterone. And I think this is erroneous on a lot of levels, because most of my provider friends or people that are NAM certified, blah, 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 will prescribe an antidepressant for women that are in perimenopause when they may actually not be depressed or have organic anxiety in the true sense. They actually have a decrease in their progesterone levels. Progesterone turns into a metabolite called allopregnenolone, and allopregnenolone will upregulate a receptor in the brain called GABA. When GABA receptors are stimulated, you feel calmer, you'll sleep better, and it just makes you feel more complete. So if you have this issue with perimenopause, you'll notice that a lot of the supplements that are out there might have tryptophan or something else in there that can help calm you down. The other thing that I talk about with regards to this are the predatory yam creams that are out there saying that it will help you with these symptoms. Yam cream does absolutely nothing. I will repeat this again. If it's wild yam cream, and that's all it is, it will do absolutely nothing. And if there are results, it's purely placebo, which in and of itself is fine. I don't have a problem with placebo. Placebo could be helpful. The problem is it's being marketed as a help, and you're spending $55 to $70 on this stuff, and it's complete nothing. It's lotion. And you need to know that going into it. That being said, there are progesterone creams available on the internet. Unfortunately, you can buy progesterone cream, a container that has 2,000 milligrams of progesterone. Legally, this shouldn't be allowed. I think it's illegal. I think it's unethical. However, these companies get around the FDA by saying that it's not a hormone cream, it's a cosmetic cream, which obviously they're lying about to get around the FDA, and they're allowing you to treat yourself. The problem is that there are progesterone receptor positive breast cancers out there. There are people that take too much progesterone. They take it at the wrong time of day. They take the wrong amount, and they're really self-treating, which I think is unfortunate, because a lot of you have to self-treat because you're not getting help from the medical community, and that's why you're out there in the first place. And so I'm definitely sensitive to that topic. But self-treating isn't really going to help you either, because you don't know what to do. You don't know how much to use. Many times the amount that's in these creams is only 20 milligrams, which might take the edge off some of your symptoms. But a prescription strength of progesterone is closer to 100 milligrams. So not only is bioidentical micronized progesterone available through insurance, might be $10, the 20 milligram dose, which is 1/5 the dose, is sometimes 5 times more expensive than the actual prescription. So you're getting bilked on one end with these progesterone creams. And then women will kind of take too much sometimes. They'll say, well, a little bit felt better, so why don't I take a lot more? And if you're doing that, then you should just be on prescription progesterone anyways, because it's going to save you some money. So that's probably the number one symptom I see in perimenopause, is this issue with insomnia, irritability, anxiety. And a lot of women, unfortunately, are reflexed to an antidepressant when they're in the perimenopause phase. And I see a lot of these women because they're like, I don't have a mental health issue. The reproductive psychiatrist on Instagram, who I've talked to a few times through DMs, we've talked about this issue with anxiety and progesterone. And there are people out there that do have, reasons for prescribing antidepressants and whatnot. And I really appreciate her take on this topic, because if you're going to be put on something like an antidepressant, I would see somebody like a psychiatrist, because there is legitimate mental health care and mental health issues that are out there. And sometimes it could very well be depression. I'm just saying, when a gynecologist defaults, or a family practice defaults to an antidepressant or an anti-anxiety medication, that this is just because they don't like to look at hormones as being the potential nidus for this issue. Another thing I see in perimenopause, obviously, we see weight gain. I see 5 to 10 pound, maybe 15-pound weight gain, usually in the midsection, in women that are around the menopause. And I have a theory on this. What I kind of look at is, if you look back the lifespan about 200, 300 years ago, we didn't really have an issue with menopause, because women on average didn't live much into their 50s. And so the lifespan was so much shorter that women didn't have menopause. And then, like, you take, for instance, my grandmother, who lived till she was 93. This is a World War II wife. Her husband went off to the war. She had 3 kids. She had to go get a job. She worked in an electrical factory. And then she hit menopause probably in the early 80s, late 70s, and they just didn't complain about it. Women were not allowed to ask questions at that time. They weren't allowed to really complain, and there really weren't a whole lot of options for them for hormone replacement at that time. It wasn't a thing. I remember asking her, like, "Hey, Graham, what did you do for menopause?" And she was like, "What the hell is menopause?" She's like, I went to the doctor one time to get a pap smear when I was 50, and I never went back. That was the mentality back then. The thing is we have become so evolved with our healthcare system that lifespans have now gone, within a few hundred years, have gone from 50 to 90. And so, because we started living so much longer, so much faster, and we have the boomers and the Gen Xers now going into this menopause phase, you have millions and millions and millions of women that are needing help. And the problem is that the weight gain, I think, is twofold. So the reason that I think your body hangs on to weight is because fat does 2 things. Fat does 2 things really well. One is it makes you more heavy. When you're heavier, you stress your bones more. When you stress your bones more, you don't get osteoporosis. So I think the extra weight gain is so that you have the ability to protect your bones. The second thing that estrogen does is or that fat does, is it makes estrogen. So if you have more fat in your body's preparing for menopause. That's what it's doing. And in preparing for menopause, it's preparing for that decrease in estrogen. So it's holding on to fat. If you give the body adequate estrogen, if the body has estrogen and it senses there's estrogen around, it may be less likely that your body would want to then hang on to that estrogen. Now, keep in mind, that's a theory. That's not something that has ever been proven. I don't know if it could be proven or not, but I would honor your body for doing what it needs to do in preparation to prepare you for menopause. But suffice it to say, weight gain is not an easy topic. It's multifaceted. I think women have increased rates of issues with weight, with metabolic syndrome, where they have insulin resistance and blood sugar issues. And that also can add to weight gain. And I think that should be considered a part of perimenopause, is this weight gain, because it's experienced by so many women. So we have insomnia, we have weight gain, and then another big one is fatigue. I see fatigue all the time, probably in the top 3 things that I hear all the time. Fatigue is not normal, especially if you feel like the fatigue is interfering with the way that you want to live your life. If you don't feel like you can be the person that you want to be because of your fatigue, That's not normal. And for anybody to tell you that, oh, you're too young, or, oh, it's just part of getting older, whatever the gaslighting comment is, you know what's normal and abnormal for you. However, I will tell you, I see fatigue in two cases. Most physicians, when they look at labs, if they even order your labs, but most physicians, when they see your labs, will just look and make sure that everything's in the normal range. So let's just say you have your blood drawn and your testosterone, your free testosterone, is in the bottom 20th percentile. So a free testosterone is 0 to 6.4. Let's say you come back around 0.5. You're in the normal range. So they'll look at this number and they'll go, well, that you're normal. But you could multiply that by 14 and it might still be normal. For a woman, 12 or 13, still be normal. It's a huge range. The side effects of having a low testosterone in women. Now, keep in mind, I've discerned this from about 50,000 patient encounters, and testosterone deficiency by far is the number one hormonal issue that I see. Fatigue. You want to take a nap around 4 or 5 in the afternoon. Hair thinning. Decreased drive, motivation, desire, the need to you just can't get motivated. The weekend comes, Friday at 5, you shut the door and then you don't come out till Monday. Things you used to like to do, your friends are like, hey, let's go do this. And you're like, nah, and they're, oh my God, you used to love doing that. I know, I just don't feel like it. I've often joked that if it was a t-shirt, it would just say meh, because that's just how you feel. So if you feel that way, and the effects of that are to the point where you don't like the way that you are, that you feel like it's interfering with who you want to be, then for you, that level of testosterone just simply isn't normal. And you might need more testosterone, and you may have to push to get more testosterone. So just remember that it's not always fatigue isn't just because you're getting older. The other reason for fatigue in the perimenopausal state is a subclinical hypothyroidism, meaning you're not meeting the clinical criteria in the sense that you meet it with labs, but you do have a lot of the symptoms. And symptoms of a low functioning thyroid would be, again, just sluggishness and fatigue, hair thinning, brain fog, weight gain, cold intolerance. You just don't feel good about yourself. You don't feel engaged in your life. And so let's look at a free T3. Again, it's a range of 2.2 to 4.4. Let's say your free T comes in at around 2.4. Well, then that's in the basement of normal. We could almost double that number and it would still be normal. But you might have all the symptoms and you might be at 2.4, and maybe bumping your free T3 up to 3.3 might make you feel better because it gives you a little more oomph, a little more pep. That is a very common archetype as well that I call the underdog in my book, The Hormone Balance Bible, because you aren't able to live up to your potential and you're not able to do the things you want to do. Another issue I see with perimenopause is hair loss. And I just talked about testosterone and thyroid. Hair loss is very common. Now, most doctors will tell you that it's stress related, and that's not wrong. That is the number one reason for hair loss, and it's very transient. But hormones, thyroid and testosterone, stimulate hair follicles to grow hair. Progesterone slows the hair from falling out. It freezes the hair growth cycle in a stage called telogen, which is right before the hair falls out. Now, when do women have their best hair? Is when they're pregnant, because their progesterone levels are so high, it stops the hair cycle from falling out. So women have this amazing, luxurious hair when they're pregnant. And then what happens? They deliver their baby, their progesterone drops dramatically, and they lose all this hair. I mean, how many times have you personally been pregnant, or have a friend that's pregnant, or that I've seen women postpartum and they complain about hair loss? It happens all the time. My drain is full of hair. That's not necessarily hair loss in the sense of you're losing active hair. You're losing the hair that was going to fall out for the last 3 months of your pregnancy, but that held in place. However, it's because progesterone stops it. So we want to look at progesterone, we want to look at testosterone, we want to look at thyroid for hair. So we've got hair loss, we've got fatigue, we've got weight gain. I would throw in there decreased libido, although decreased libido obviously is a multifaceted thing as well. I'll probably do a podcast on that one because I get a lot of women that will come in and they'll say, I have a decreased libido. Well, it's normal to have a decreased libido at times in your life because, you're not just a sexual machine that you can turn on and off. For women, the sexual response, the first stage is arousal. And in order to get into the arousal phase, it might indirectly be related to your testosterone level. However, if you're severely fatigued, you're not going to get aroused because you just don't have it in you. If you are just stressed out, if you're not sleeping, if you're worried about money, if your relationship isn't good. So you can see there's a lot of what we call supratentorial effect, meaning above your neck. It's in your brain for women with decreased libido. And I'm not saying it's in your head, it's in your psyche in the sense that you're just not interested in sex because you're just not in a part of your life where that's super important to you, or your hormones are off and you just don't have the energy. So you're not interested, which is different for men because our testosterone levels are always higher. And for men, you just need to wake up basically with an erection and you can have sex. For a woman, it's more of a process. And the thing is, and I said this the other day on Instagram, men don't spend the time to get their partners in the mood. It's not about coming up to her in the kitchen and putting on your best moves. It's about doing the dishes. It's about giving her the time to get aroused. It's about taking care of her and making her feel like you got her back. Now, I always put in the proviso that I am not a relationship expert. I am actually divorced. So obviously I have things to learn as well about relationships. But in talking to women for the last 20 years, that topic comes up over and over. Now, the decreased libido aspect, if it's something that you don't like because you used to be sexually active and you used to enjoy sex and now you're just not feeling it, then that can be a problem for women. But I always ask women that come in for decreased libido, are you coming in because it bothers you, or are you coming in because it bothers him? And in a lot of cases, it's not because they're bothered by it. They could take it or leave it. It's because he's pushing them and what that does though is that then has a negative effect on sex drive because it's more stress. If she has to worry about the way that you're thinking about her because she's not interested in sex, then that can affect the sex drive as well. So that's a big one. If we look at some of the smaller things that I see in menopause, perimenopause, hot flashes, you'd think that those would be more common. They're not particularly common. Sometimes we will get women that have issues with just having hot flash here and there, night sweats. But if it gets to be overriding, it's interfering with the way that you want to live your life, then that could be a problem. And again, we'll look at estrogen dips and see where you're feeling your worst. And you can always replace progesterone and estrogen in perimenopause. The question, do you have to cycle? That's a different topic. I talk about that ad nauseum on my Instagram page, and I have a podcast about that as well. And I don't think you have to cycle. If you want to, you certainly can, but it's not mandatory. It's not something you have to do. So, so those are the big things with perimenopause. I just wanted to demystify the fact that perimenopause isn't something that we can just like wave a magic wand and we give you this diagnosis. Perimenopause is a consortium of signs and symptoms that we then combine with labs to see if you fit a certain profile. It's not a diagnostic thing. So don't think that, oh my God, I have perimenopause, I have a problem. It's just a thing. It's a time period. It's around your menopause. And it's not something that has to be horrible at the same time. You may have a couple of hormonal issues. It's always good to check your hormones. If your doctors are telling you that you don't need to check hormones, they're just being lazy. If they give you the excuse that they're always changing, it's basically that what they're saying is they don't know what to do with the numbers. They're not really interested in listening to your story. And as such, you're getting kind of shafted a bit. So I wouldn't worry about doctors that do that. You don't need to go to them. You can always find somebody else that will draw those labs for you. As always, and I say this all the time, it's not a shameless plug, but I do think a good place to start is with the Hormone Balance Bible. I think it gives you the 12 most common hormone imbalances in women. It's on sale on Amazon right now for about $14 to $16. 500 pages, talks about testing, talks about each hormone and what it does. And then I go into the top 6 hormone imbalance, or the top 12, hormone imbalances for women. And I have a Shines protocol that's a 6-step process for fixing those hormones and for giving you 5 options out of those 6 that you can do by yourself at home and not something that you have to struggle with. And sometimes supplements and working out and food and diet and stuff can work for some people and not work for everybody. I do think that hormones have the biggest bang for the buck, depending on what your issues are. And I think that you getting to the healthcare provider that will provide you with the right tools is essential. I'm currently licensed in about 27 states. If you go to my Instagram at Shawn Tassone MD and look up my second pinned post, I have all the states listed there where I am covered. So if you are in one of those states, we can do a virtual visit. I don't take insurance. However, I don't feel as though I'm gouging people either. I usually charge for my visits what I would have charged your insurance anyway. We do give women, after the visit, we'll give you a sheet that you can submit to your insurance that has the codes and CPT and ICD-10 codes, so you can submit it to your insurance for reimbursement, and you may get reimbursed for that. Keep in mind, there are bioidentical hormones out there as well that are commercially available through your major pharmaceutical companies. There's micronized progesterone, there's bioidentical estradiol. There is not a form of testosterone that is available to women through regular pharmacies, so that has to be compounded. It's a shame, but the medical system has not felt that women need testosterone, even though it's the #1 circulating hormone in your body. They feel like testosterone replacement isn't important. So even though there's been about 5 or 6 companies that have brought testosterone replacement to the FDA, they've never approved one for women, even though there's about 12 for men. It's really unfortunate, but it's definitely available to you as a compounded hormone. You just have to see a person that actually knows what they're doing. So perimenopause, just a stage of life. It could be horrible. It might not be horrible. But if it is bothersome to you, obviously reach out to a healthcare provider. Don't always think that the NAMS certificate or the North American Menopause Society certification means anything, because a lot of those providers only do what NAMS tells them to do. They won't look outside the box. They don't like to order labs, and they definitely don't like to prescribe testosterone. So find a provider that you resonate with. Go with them. Find somebody that you feel like you're going to get the help that you need and that you deserve. I hope you have a great weekend. As always, I do Instagram posts on Saturdays. I do a Q&A. I do a live session every day for about 10 minutes on my YouTube channel. And I will also answer live questions on YouTube. So hopefully I'll see you there. Have a great day.